So good afternoon, everyone. I'm delighted to share my experience with you on syndrome of Quadriga. We'll be focusing on pathomechanics. We'll look at the management, but at the same time, we'll be talking about how to prevent Quadriga effect on the hand. So you see many patients who have had different types of hand injuries, but we never think of Quadriga effect that often presents us with many challenges. So looking at the historical perspective of Quadriga concept, the Flexor Quadriga was first introduced by Verdun back in 1960. 28 years later, Willem, a German surgeon, identified that extensors have a similar phenomena, and therefore he reported on extensor Quadriga. But many times a question arises whether flexor Quadriga or extensor Quadriga can convert into flexor or extensor Quadriga. Because ultimately, number of changes occur as a result of limitation in tendon excursion that will ultimately produce limitation in joint motion and subsequently produce various biomechanical challenges. So looking at the term Quadriga that was coined by Verdun. So the concept, he derived the concept from a Roman chariot, which was powered by 4 horses. He further added that if one of the reins of 4 horses became deficient, either loose or tight, that will have an effect on adjacent horses accordingly. So the Quadriga concept, therefore, he applied to the flexor digitorum profundus. Anatomically, he identified that profundus has a common muscle belly that connects to your index, long, ring, and small, majority of times, but at times it may spare index, however, it may still have connections with long, ring, and small fingers. So looking at this picture, you can see that one of the horses are deficient in terms of having a balance, and therefore that was having an effect on adjacent horses accordingly. So how Dr. Verdun pointed it out to us about syndrome of Quadriga, he mentioned that muscular body of the flexor tendons can act very efficiently if the gliding amplitude of each and every tendon is normal. He also identified that flexor digitorum communis being a common muscle belly, therefore, all the fingers should move together if every tendon excursion is unrestricted. So we carried out few experimentation in our biomechanics lab to see what happens. So here I'm pulling on long finger flexor tendon, and I'm noticing that as I'm pulling on the long finger flexor tendon, all the other fingers are flexing at the same time. So Verdun suggested that if one of the tendon is deficient or tight, tethered, or has caused some changes in terms of joint mobility, then that will have an effect on motion of all the fingers. So as you can see the clinical situation right here, the person has stiff little finger following flexor tendon repair. You can see that the ring finger, long, and index has, all these fingers have incomplete flexion at the proximal interphalangeal joint as well as distal interphalangeal joint. So here, of course, I'm going to run this video for you to see in a cadaver what we exactly see from Quadriga point of view.
Hold the ring fingers. It's stuck. So that's Quadriga. So the moment I let go the ring finger, these two will follow. Isn't that beautiful? Hold the ring finger.
So in order for us to exactly understand the mechanism of Quadriga effect on the hand, we must understand the mechanism of normal finger flexion. So even though the diagram here shows just one finger, but we have to consider all the fingers together. So we know that when we initiate finger flexion, even though profundus and superficialis are acting together, flexor digitorum superficialis initiates PIP flexion first. And subsequently, your oblique retinacular ligament becomes slack, allowing profundus to then create tension on the distal interphalangeal joint, causing DIP joint to flex. And gradually, as the PIP and DIP joint flexion increases, your lateral bands start to migrate volar to the anatomical axis of rotation at PIP joint. With increased amount of PIP and DIP joint flexion, your extensor deuterorum communis moves the sagittal band distally at the metacarpal phalangeal joint, which then helps in increasing excursion of the intrinsic, and this is how we complete flexion of our fingers. But based on this, you can very well imagine that if profundus of one finger is stuck, then that excursion of profundus doesn't increase mechanical motion at the proximal interphalangeal joint as well as distal interphalangeal joint. And as a result, that finger is going to interfere with motion of the adjacent excursion of the tendons, and therefore the patient will have loss of motion of adjacent fingers as well. So in other words, we can see that if one profundus is cut down because of flexor tendon repair at the side, then excursion in that finger is lost, but adjacent finger is lost as well. So if we look at the flexor and extensor intricate arrangement, we can see that flexors and extensors share an intricate or very delicate relationship with each other. So as we initiate flexion, we can see that the excursion of the tendon occurs as the finger is moved from extension to flexion and vice versa. So if flexors are tight or adherent, the extensors will have decreased amount of excursion proximally as well as distally. And vice versa, if extensors are tight or tethered, then flexors will have decreased mobility distally as well as proximally. And considering this, then it is going to have a significant amount of effect on the joint and joint mobility. So if the tendons don't glide, the joints become stiffer. And if the joints become stiffer, the tendons further lose motion. So therefore, we can say that if the joints have become stiffer, then neither extensors nor flexors will have an adequate distal as well as proximal excursion of these tendons. So now let's look at conditions where the flexor quadriga is likely to be present. If patients have extensor tendon repair and they have been immobilized, or the hand has been immobilized, then extensor contractures form. And once the extensor contractures form, then it limits the composite flexion of metacarpal phalangeal joint as well as interphalangeal joint, and that leads to flexor quadriga. The other situation where you're likely to see the quadriga effect is on when flexor tendons are scarred down following repair. So reduced gliding amplitude of flexor deuterorum superficialis and profundus, mainly the profundus, will lead to decreased amount of motion at the PIP as well as DIP joint. And as a result, patients will have lost excursion of the tendon, which significantly is going to affect mobility of the joint. We have been seeing two-stage flexor tendon graft in the past, and then we know that normally flexor deuterorum superficialis is excised and is sacrificed. It's only the profundus tendon that is reconstructed. So now we have one tendon working on three joint system. So when you ask a person to flex the fingers because of the tendon having lost excursion, the mobility of the finger is lost. And in such situations, patients will have a strong lumbrical plus tendency. We treat a number of phalangeal fractures. We know that in olden times, following a proximal phalangeal fracture, the reduction was often carried out by putting an intramedullary K-wire. And that caused adhesions of every structure, extensors, flexors, intrinsics, and so on. In such situations, of course, gaining motion of the PIP and DIP joint is very challenging. And not only the affected finger loses motion of the PIP and DIP, but adjacent fingers also lose motion, as you can see the central picture right there. Of course, depending on the type of fracture the person has suffered, then it's often considered necessary for fixation by using plate and screws. In this situation, of course, you can see that even though long finger is involved, flexion of your index, ring, and small is affected as a result of long finger losing motion at the PIP and DIP joint. So we can say that when excursion of the profundus is reduced due to adhesion formation, that is going to cause an effect on flexion of the adjacent digits. So this is a patient who has multiple fingers involved in a form of a flexor quadriga. However, the ring finger here, as you can see, is the affected finger, but other fingers have lost its mobility. PIP joint dislocation often causes swelling, pain, and limitation in the joint, despite a finger being reduced. So here the person has a PIP joint dislocation of the ring finger that is reduced, and upon reduction, patient had limited motion of the PIP and DIP joint. So we often focus on moving the fingers from extension to flexion after reduction. However, we don't pay much of an attention to a person having a superficialis deficiency. So this is quadriga secondary to D5 limitation that was produced by ring finger stiffness. Here, of course, you can see the ring finger is dislocated. It has been reduced, but looking at the pattern of motion, you can see that the patient is having limited motion of the small finger, limited flexion of the ring, and of course the index finger as well. So it's essential for us to look at whether the person presents us with deficient superficialis, and if it does, if the patient has deficient superficialis, you'll definitely see patients will have a reduced motion of the adjacent digit. So, and that is the limitation is magnified. So this particular individual was complaining of pain and stiffness of the whole entire hand, right from index to small, even though the small finger was spared in a way, but the ring finger was dislocated. But because the ring finger was stiffer, the excursion of profundus on the small finger was lost, and that deficient superficialis was creating a mechanical disturbance on the adjacent fingers. So let's keep in mind that the stiff ring finger and having a presence of deficient superficialis is inducing the whole entire hand or influencing the whole entire hand, causing it to become stiffer because it is contributing to the quadriga effect. So it was a question as to which finger produces significant amount of quadriga effect. So we carried out a study and identified that when the finger is stiffer, then it produces quadriga effect. However, we identified based on our study that ring finger was the most problematic finger. If it becomes stiffer, then it produces the greatest amount of detriment, somewhere between 26 to 47% reduction in total active motion. So it's essential for us to consider that if the ring finger is involved, we need to, or any finger for that matter is involved, we need to maximize. However, ring finger played a major role in producing severe quadriga effect. So in order for us to understand the complications associated with flexor quadriga, we know that limited motion of the adjacent finger as well as the involved one is going to produce severe secondary joint stiffness. And then as a compensatory mechanism that person does, loss of flexion of the PIP joint is compensated by hyperflexion at the metacarpal phalangeal joint because intrinsics are trying to pull or compensating for loss of PIP joint. So increase, and that will cause increase in articular compressive forces leading to joint pain. And we have seen some patients who have gone into marked stiffness of the fingers. They often have some premature arthrosis. Patients often will have a reduced grip strength and definitely have reduced functioning of their hand. We'll now move on to extensor quadriga. The first paper that was published it's in German language, published by Willem. It was published in Hand Microsurgery Plastic Surgery Journal back in 1988. So similar to the mechanism of flexion, it's important for us to understand the mechanism of normal finger extension. When the fingers are fully flexed, we initiate motion by using a central slip. So central slip initiates PIP joint extension first, and being a part of central slip, being part of extensor determined communis, your lateral bands are equally tensed, and lateral bands then gradually extend the distal interphalangeal joint. With increased amount of PIP and DIP joint extension, your extensor determined communis glides proximally. With increased amount of gliding of the extensor determined communis, as PIP and DIP joint extension increases, the sagittal band is pulled more proximally. With increased motion of the PIP and DIP joint towards extension and motion of the sagittal band proximally with extensor determined communis, we then see the extension of the metacarpal phalangeal joint. So it's a complex process. And later on, when the fingers, the excursion has moved, the excursion of extensor tendon has moved proximally, the sagittal band in collaboration with your extensor determined communis and intrinsics, then it produces greater extension of the PIP and DIP joint. So at this stage, all the three joints are perfectly aligned. But you can imagine that if the person has an extensor tendon adhesion proximal to metacarpal phalangeal joint, despite of PIP and DIP joint motion increase, since the extensor determined communis has a limited gliding proximally, it will produce lack of extension at the metacarpal phalangeal joint, and that will subsequently produce extensor lag of the involved finger, but subsequently you'll see there'll be an extensor lag of the adjacent digit. And we term that as extensor quadriga. So we looked at few of our metacarpal fractures, few of our cases who had extensor tendon repairs on the dorsum of the palm proximal to the MCP joint. We identified that lack of extension definitely produced extensor determined communis to have a limited excursion of the involved finger, but contributing to limited extension of the adjacent digit as well. So loss of EDC excursion in one finger resulted into a loss of extension of the metacarpal phalangeal joint of the adjacent fingers as well. So here, of course, we can see that once we insert the K-wire here, I don't know why this video is not playing, but anyway, so we looked at the decreased gliding amplitude of extensor determined communis in one finger, reduced the excursion of adjacent extensor determined communis accordingly. So this is the first paper that I wrote back in 2004. This has gone through a series of reviews by experts and then finally got accepted for publication. But until such time, the extensor quadriga, the entity was not at all known. So conditions where extensor quadriga is likely to be present, we have seen that this is often seen with extensor tendon adhesion following repair, proximal to zone 5. We have seen that extensor tendon has a high possibility of adhesion formation at the fracture site following metacarpal fractures. And we noticed that if a person has a ring finger or small finger metacarpal fractures, if the tendon is scarred down at the fracture site, then there was CMC or hematometacarpal joint hyperriding or hyperextension that is quite common with fourth and fifth finger. And we identified that further dropped extensor tension because of hyperextension at the hematometacarpal joint, and that contributed to severe loss of excursion of extensor determined communis. The other situations where we identified that what we identified was the sagittal band rupture is often quite common form of injury at the metacarpal phalangeal joint. And having lost the sagittal band support or stability, the finger droops in extension. So here, of course, I'm going to run this video again. You can see that the person has reduced excursion of the extensor digitum communis at the metacarpal phalangeal joint right here as a result of sagittal band tear. But if you pay closer attention to extension of the index and ring, we can see that these two fingers are also affected as a result of lack of complete excursion of the long finger. Whereas small finger, if we took the extensor digiti minimi out, we'll see that the small finger will also show the extensor lag at the metacarpal phalangeal joint. However, here, of course, the persons demonstrate a strong tendency to abduct the finger, compensating for loss of extension. So in this situation, you'll see that the finger will have a strong tendency to abduct much more strongly because of the extension that is being performed by extensor digiti minimi. So in rheumatoid arthritis, sagittal band attenuation is very common. You may start off with one finger involvement, as you see in the cadaver model right here. So one tendon falls in an ulnar valley, subsequently that produces a tension on your juncture tendinum, and that juncture tendon will pull the adjacent tendon in an ulnar valley again, changing the alignment of the extensor tendon in general, right from the extensor retinaculum onward, and subsequently the fourth and the third extensor digitum communis will also slip in an ulnar valley, producing a severe quadriga effect. So while carrying out some cadaver dissections in our biomechanics lab, we came across this particular specimen. We noticed that the person probably had punched someone in the mouth. As a result, the extensor tendon had severe trauma, and of course, there's an articular problem as well. And then the tendon got scarred down at the site, the fracture site, as well as the trauma to the extensor tendon. And upon pulling on extensors, we identified that there was an extensor loss at the metacarpal phalangeal. So syndrome of extensor quadriga is definitely exists. We can say that the deficient EDC excursion of one tendon is going to affect the adjacent tendons as well, producing a quadriga effect. It's very important for us to consider the possible complications associated with extensor quadriga. We know that extensor lag at the metacarpal phalangeal joint that will always lead to an adaptive shortening of the palmar intraosseous muscle. And as the palmar intraosseous muscle becomes tight or undergoes tightness, it is going to increase an intrinsic force at the PIP joint, causing a PIP joint to go into a swan neck deformity. So other complication of extensor quadriga is the increased intrinsic force at the PIP joint that causes swan neck deformity, and that will lead to intraosseous contracture. And gradually over time, as the person keeps on using the fingers for functional activities, the intrinsic that have undergone adaptive change is going to increase the load on the base of the proximal phalanx, further causing volar subluxation of the proximal phalanx. And that has been seen in rheumatoid arthritis. In addition to that, it is going to produce an ulnar drift, because the alignment of or line of pull of the extensor digitum communis is now altered, and as a result, the fingers are now deviating toward the ulnar side. So, and that will further increase the load on the intrinsics that are on the radial side, increasing the load at the PIP joint, magnifying ulnar drift, as well as volar subluxation of the metacarpal phalangeal joint. In addition to that, increasing the load at the proximal interphalangeal joint, giving you severe swan neck deformity. But we don't stop right here. We can see that other complications are likely to arise as a result of extensor quadriga. Because we have seen that when the finger goes in hyperextension at the metacarpal, as the PIP joint goes in hyperextension as a result of the EDC subluxing, the person eventually will have dorsal translation of the lateral band, leading to like a mechanical effect or mechanical tension band effect at the PIP joint, producing a flexor quadriga. So looking at the management of quadriga, we can see that we can define that any clinical condition where flexor tendons are likelihood of losing excursion due to adhesion formation or joint stiffness is going to produce flexor quadriga. So far we have seen that if patients have flexor tendon repairs, flexor tendon graft, proximal or middle phalangeal fractures, or PIP joint dislocation, or PIP joint contractures will produce a quadriga effect. And then, of course, if the patients have gone into a swan neck deformity of any origin, will also lead to a quadriga, flexor quadriga effect. So swan neck deformity is not a clinical diagnosis. It's a symptom because of some primary pathology, and therefore it's essential for us to look at what is the primary pathology and treat that individual in accordance with their primary injury so that we can maximize mobility of the PIP joint. So in general, the management is based on thorough understanding of the primary pathology. It's important that we restore passive mobility of the joints if the joints have undergone physiological changes. And then once we have gained the motion of the joint, we can attempt for maximizing excursion of the flexor tendon, that is flexor determinum profundus and flexor determinum superficialis. And of course, we can initiate with early control motion program in a short arc of pattern of motion, allowing patients to perform active tendon gliding, which is always advantageous over passive motion protocols following flexor tendon repairs. However, since I brought it to the attention of everyone that patients may go into a quadriga effect as a result of deficient superficialis. So therefore, it is essential for the surgeons to share information about deficient superficialis so that they are familiar with the quadriga effect that will produce a stiffness of the adjacent fingers as well. So consideration, therefore, is mobilization of the small finger in every case so that we maximize flexor determinum profundus excursion, especially when patients have deficient superficialis. The prevention is definitely ideal because we don't want these patients to go through multiple changes over time because of lack of mobility of the involved finger and lack of mobility of the adjacent fingers as well. So how do we treat proximal phalangeal fracture? As you can see that this patient has open reduction and intel fixation. And then, of course, we begin with early control mobilization program. Obviously, the patient was fitted with an intrinsic plus plane, making sure that the PIP and DIP joint are held in neutral when the MCP joints are in flex position. So since profundus is the culprit, if it gets tethered, you lose excursion of the profundus tendon. So therefore, it is essential not only for us to initiate PIP joint profundus and superficial gliding, but if the person has limited motion of the distal interphalangeal joint, then it's preferred that patient be fitted with a circumferential splint so that there is no direct force transmission at the fracture side as you are mobilizing the DIP joint to maximize excursion. And then working on the motion of the PIP and DIP joint, you can maximize the person's ability to flex all the fingers and retain flexion of not only the involved finger, but all the fingers. When we see two-stage flexor tendon graft, you have one tendon working on three joint systems. And in this situation, you'll often see that if the flexor tendon excursion is somewhat reduced, you have incomplete flexion of the PIP and DIP joint. And in order for you to compensate for loss of that flexion of the PIP and DIP joint, many a times patients often use intrinsic severely, and then therefore patients end up having severe or greater amount of MCP joint flexion. So it's by providing these patients with MCP blocking splint, as you see right here, we are maximizing excursion of the profundus so that it is giving us greater amplitude of motion at the PIP and BIP. So here, of course, you can see that the person is MCP joint is blocked. You're maximizing profundus excursion, and here the patient is showing great motion of all the fingers. So PIP joint dislocation management, of course, upon reduction, we begin with early motion program, encouraging the patient to perform active MCP, PIP, and DIP joint flexion. However, once we know that the person has a deficient superficialis, our management would somewhat change. In order to maximize mobility of the joint, we must consider like a flexion glove or dynamic flexion splinting. So once the flexion of the PIP joints is achieved, and you can then work on excursion of profundus and superficialis to maximize digital mobility. But at times the adhesion formations are too significant and they're not sort of remodeling in the direction of stresses. In such situations, patients may require limited tenolysis following fractures of the proximal or middle phalanx. So this is a patient who has reduced motion of the PIP joint and DIP joint as a result of tendons getting scarred down. Patient underwent limited tenolysis. However, the management that we carry out following tenolysis involves extension splinting so that patients don't become, do not lose extension of the PIP joint. We begin with active range of motion of the PIP and DIP joint. However, in order for these patients to have balancing act between extensors and flexors, my preference is to perform resisted extension of the PIP and DIP joint, then active flexion that these patients perform. So looking at the cause of extensor quadriga, we know that zone 4 and zone 5 extensor tendon repairs often will have limited excursion proximally, producing quadriga effect. Metacarpal fractures, sagittal band ruptures, intraosseous muscle contractures, or MCP joint dislocation. These are some of the common factors that produces quadriga effect. We can say that any clinical condition where extensor tendons are likelihood of losing excursion of extensor determ communis proximal to the MCP joint will produce extensor quadriga. So the management again is based on understanding of primary pathology. It's essential that we restore passive motion of the MCP and IP joint. We can begin with early short arc of active tendon gliding that is always advantageous over immobilization or passive motion protocol. It's important that we maximize extensor determ communis excursion following tendon repair or fractures of the metacarpal. It's essential for us to centralize the location of extensor determ communis if the sagittal band are injured or traumatized or have become attenuated. And obviously, it is essential for us to identify the intraosseous contribution to lack of extension of the metacarpal phalange. In such situations, you may consider providing these patients with the MCP block splinting or intraosseous stretching exercises and splinting so that we can maximize anatomical length of intraosseous muscle. And of course, the prevention is always better than these patients going through all the series of changes that often are associated with tendon adhesions and producing extensor quadriga. So this is a patient who had a metacarpal fracture who was treated with immobilization method. And of course, the patient demonstrates severe extensor quadriga of all the fingers. In order for us to treat him successfully, we had to use triple body taping to encourage excursion of all the extensor determ communis tendons. And of course, we need to encourage extensor determ communis gliding exercises with PIP flex. However, in some situations, you may consider using ultrasound treatment and electrical stimulation of EDC muscle. Often patients who have had displaced metacarpal fractures, they often require open reduction and ankle fixation. In these situations, patients often have dense adhesion formation between the tendon and the fracture. So therefore, our management is somewhat different. Once the fracture is fixated by means of open reduction and ankle fixation, we provide these patients with the circumferential brace and then encourage patients to perform resisted extension with the metacarpal brace and resisted flexion, resisted extension with the metacarpal brace and resisted flexion in order to maximize excursion of the tendon proximally as well as distally. If the patients have sagittal band attenuation or in RA, whether it is traumatic or whether it is because of rheumatoid arthritis, it is essential for us to assess and treat intraosseous tightness if they have had some changes. It's important for us to assess the subluxation of extensor digiti minimi, because a subluxation of extensor digiti minimi will often cause a rotational tendency of the small finger, and therefore we may have to use a derotational taping. We can then perform sagittal band attenuation test by asking a person to, by extending the finger passively and asking the person to retain extension. If they're able to retain extension, then we must assess for the intraosseous tightness, and then we must provide these patients with MCP blocking splint so that we can maximize in intraosseous gliding exercises and maximize the anatomical length of intraosseous muscle. So this is a traumatic sagittal band rupture. The assessment is similar to what we normally do, especially with the sagittal band rupture. Patients are often fitted with ICAM splint or yoke splint, which they wear for a 6 weeks period of time. If there is a delay in terms of management, always check for intraosseous tightness and deal with that first before you manage the MCP joint by ICAM splint. So sagittal band reconstruction is often necessary if there is a delayed management. We use a yoke splint for a period of about 6 weeks. Initially, we'll begin with 60 degrees arc of motion with 10-degree increment on a weekly basis, and it will initiate strengthening at 10 weeks. So looking at the results of the repairs is much better. As you can see right here, the person has full range of motion and no extensor quadriga and has a complete ability to flex MCP and IP joint. So I briefly mentioned about the convergent quadriga. I'm just going to present a case, and I'm sure that some of you may have come across these type of cases in your clinical practice as well. So flexor quadriga, the question arises whether it will change to extensor quadriga, and the other question is whether extensor quadriga will convert into a flexor quadriga, and whether we can call this as conversion quadriga. So this is a 57-year-old young fellow who has a right hand dominant injury. He lacerated his extensor digitorum communis proximal to the metacarpophalangeal joint of a left long finger. Sorry, he was right hand dominant, yes. He had a surgical repair of extensor digitorum communis, and here you can see the location of the tendon repair. This patient was managed sent elsewhere. He received the therapy locally, and of course, his therapy involved post-operative splinting with wrist extension and MCP joint and slight flexion. His hand was placed in the splint for a period of about 5 weeks. He began with early tendon gliding at 5 weeks post-operatively, and he reported that he had difficulty extending his fingers at the big knuckles initially, but he notified that after some time he started noticing that his finger is going backwards, especially the small finger at the PIP joint. And at the same time, he had some difficulty bending his PIP joints. He had quite a bit of pain in the adjacent digits as he attempted flexion. So obviously, because of the lack of extension of his finger, he started noticing that the extensor quadriga that he has gone into was leading to some changes, going into periarticular changes and stiffness. He was referred to hand therapy after being seen by one of our specialists at Hand and Upper Limb Center. On examination, we identified that he obviously had snapping swan neck of his small finger. Pain on visual analog scale was reported to be 7 on the adjacent fingers, small finger 6, and he was complaining of pain in his PIP joint. On examination, he had about 80 degrees of motion of the PIP joint. He had about 45 degrees of flexion in his index, long, and ring finger. The small finger showed a swan neck tendency with DIP joint in about 30 to 35 degrees of flexion. So this snapping swan neck that, as you see, was becoming more profound in the small finger. However, the other PIP joints were starting to hurt as well as a result of extensor quadriga. On examination, we identified that patient obviously had a strong intrinsic tightness in the small finger. He also presented with a dorsal capsular and intrinsic tightness in his adjacent fingers. He had a reduced FDP excursion as a result of intraosseous tightness, and then the tension band effect that was produced by his lateral bands, which had translated somewhat dorsally. And on examination, it was obvious that he had some snapping of his fingers, mainly on the small finger, but the other adjacent fingers were starting to show the tendency towards the same. So we decided not to assess his grip and pin strength because of his complaints of pain. However, the patient was independent in activities of daily living. So on examination, the patient presented with intraosseous tightness of various degree of various amplitude, as you can see in different fingers. And of course, he had gone into the extensor quadriga, and then this extensor quadriga ended up converting into a flexor quadriga. So here, of course, this videos definitely demonstrate that he was unable to flex his fingers completely, and then he went on to developing the flexor quadriga secondary to extensor quadriga, that's what he originally had. So obviously, we had to manage this patient in therapy, mobilizing his fingers, making sure that we are regaining anatomical length of intraosseous muscle. And then patient, of course, required surgical intervention, and post-operatively, so let's go back. So post-operatively, he was managed in hand therapy. So patient required dorsal capsular release of the PIP joint, especially the small finger, because that was contributing to inability to flex the ring as well as long and index finger. So he had a PIP joint tenodesis at pinning of the DIP joint in extension temporarily for a period of about 4 weeks. So his therapy involved patients being placed in a PIP joint dorsal blocking splint. PIP joint was held in 30 degrees of flexion. We began with active range of motion and passive flexion of index, long, and ring fingers so that we are maximizing the joint motion so that they don't cause recurrence of quadriga effect. The small finger PIP joint range of motion was started in the splint on 4th post-operative day. The status at 5 weeks, the PIP joint flexion increased to 75 degrees. That was acceptable considering his swelling and discomfort. His index to ring finger range of motion was excellent, ranging from 80 to 85%. Patient mentioned that he had significantly reduced pain in his hand. His prognosis was considered acceptable or excellent to date. So at 10 weeks post-operatively, we finally gained good range of motion, full range of motion. However, we still had to keep the PIP joint of the small finger in slightly flexed position with the silver ring splint. However, he continued using the splint for additional 4 to 5 weeks. And by the end of about 13 to 14 weeks, his grip strength was excellent, almost close to desirable level. He had 42 kilograms of grip strength as compared to 50 on the contralateral side. And at this stage, patient returned to work with no restriction. So you can see that the extensor quadriga can convert into a flexor quadriga. And if a person goes on to having flexor quadriga, especially with limited excursion, it's quite likely patient may revert back to extensor quadriga. So therefore, it is very essential for us to identify the limiting factor and keep in mind that these changes occur on a very slower pace basis, and therefore they require specific attention in terms of diagnosis, in terms of evaluation, and in terms of management. So here, of course, this is his final results. As you can see, patient has full range of motion, no joint stiffness, no pain at this stage, and no discomfort. So in conclusion, we can say that secondary complications of flexor and extensor quadriga are many, and they are preventable with our understanding of the quadriga syndrome and, of course, what is involved in quadriga syndrome. Presence of extensor quadriga is generally not known, and I remember having numerous dialogues with Dr. McFarland when I presented him with 1 or 2 cases stating that these patients are exhibiting extensor quadriga. I was not believed. He said, oh, there's no such a thing as extensor quadriga. I presented on extensor quadriga in one of the hand surgery meetings, and fortunately at that stage, that time, Dr. Paul Manske, who was chief editor of American Journal of Hand Surgery, he invited me to submit my article on extensor quadriga. However, the peers did not see extensor quadriga or had not experienced or heard of extensor quadriga. Therefore, that paper was not actually chosen for publication in American Journal of Hand Surgery. With the Dr. McFarland's persistence and, of course, his encouragement, he recommended me to submit that paper for Canadian Journal of Plastic Surgery, and that got accepted. It went through quite a lengthier review process, and finally it got accepted for publication. So extensor quadriga complications are a lot more serious as compared to flexor quadriga, and this is something that we have to keep in mind. So intrinsic tightness, which are commonly seen with extensor quadriga, they increase the joint compressive forces, causing pain and discomfort, and ultimately stiffness and limitation of severe kind. So extensor quadriga is likely to transform into flexor quadriga, and this is something that we have to keep in mind. And as a result, patients often may exhibit hyperflexion of the metacarpal phalangeal joint, which is common with flexor quadriga, and these are some of the complications that are likely to magnify if we are not paying much attention to this quadriga phenomena with these patients who have suffered injuries to their skeletal system or their extensors or flexors. So therefore, in concluding statement is early detection and management of quadriga of either flexor or extensor. Therefore, early detection and management therefore produces favorable results. Thank you.